My name's Susie. I work in the health team at Sport England, and I mainly lead on mental health work for the organisation. Recently, oh, sorry, could everyone turn on mute? I've got quite a lot of background noise coming from, sounds like other offices. That's fab. Thank you. It's really distracting. So yeah, I work in the health team at Sport England and lead on mental health for the organisation, and I've been doing some work in recent years with NHS Talking Therapies, and this is part of our sort of wider work area to embed physical activity into integrated care systems locally. And I guess this is taking a bit of a laser approach in terms of looking at a small mental health service area. It's quite attractive because there are over 150 across England, and what they deliver is quite similar, but how they go about it is different. And we started a pilot 3 years ago with Camden, Islington and Bucks Talking Therapies to understand a bit more around how you can connect with your local physical activity assets and build those pathways so that there is the psychological treatment as well as some physical activity alongside. So this wasn't a physical activity instead of talking therapy, it was alongside and in conjunction with. And more importantly, we wanted to understand, like, how do you actually do that in practice? And so how does a service start to work and form relationships with local partners? How does that work when you roll that out wider to a service offer? How do you deal with recruitment? How do you have those feedback loops? How do you measure the clinical outcomes so we can understand what the impact is? So we did that over the last 3 years with those 2 sites and tested a number of interventions that you can see in the report that was out this week, and it gives a flavour of some of those clinical outcomes. I caveat the whole pilot with the fact that it ran through COVID. So we had a big discussion on whether actually do we go ahead and do this, or do we wait till restrictions are removed. But actually, given that the pressures with talking therapies and actually moving online may be something that people were interested in, and in service routine anyway, we did pivot the pilots and did a lot of the work online. And then as restrictions eased in that 3rd year, we were managed to do a bit more of what the original plans were. And alongside that, and off the back of that and all the learning, we have created a bit of a toolkit. So there are sort of 5 steps that any service can sort of go through that we learnt through the pilots that was quite effective in terms of integrating this into a service. So those 2 resources are out, and given the fact that we ran it through COVID, and the evaluators backed us up on this, we felt we didn't quite have enough information to roll out to a scaled recommended model of best practice. It was almost like we found loads of good stuff, but we actually need to go that step further before we start recommending this is an approach that fosters some of the shared outcomes that lots of sport organisations have and also health organisations have. So we want to go further and bring on some new sites that are willing to use some of the learning that we have and we've got to take that further, basically get some more service users through that, find some more learning and understand a bit more about some of the things that we weren't able to get to. So for example, that ICB engagement, because of the sort of infrastructure changes that were going on at the time and the sort of mobilisation of those, the way local health services were looking and feeling, we had less engagement through our pilots. So we're also looking at getting a bit more ICB engagement here to make it more sustainable and more of a sort of system process, and also return on investment. So we start looking at the return on investment for a service and maybe some sort of longevity of actually when you bring in these conversations around physical activity and it's important, what does that look like for patients in the longer term in terms of service utilisation. So there's lots of different, what I would say, buckets that we're interested in. So there is whilst there's learning and some parameters around it in terms of what we want to find out and how we can work together, there's also definitely the flex of what your local assets, what might work for you. to sit alongside that and shape the work. We have some guidance that's coming out hopefully on Monday that goes into far more detail than I'm explaining around timelines, the process, etc. So yeah, that's it in a nutshell. We would then hope that the Trailblazer sites obviously have their local evaluations, and then that's fed up into the national evaluation. So we hope to have a relationship with those local evaluators and aggregate that learning up. And what I'm really interested in, being in the policy and integrity directorate, is informing our influence in advocacy with like the National Health Service, for example, and using all the data and the information from the local sites to inform some policy changes in the longer run. We also have a really good relationship with the national team and added in a segment into the national operating manual in this latest update around physical activity, these pilots, and the role that active partnerships can play in supporting this agenda. So we have that existing relationship, and we're trying to really enhance that through this work as well, so that there's a bit more of a line of sight around what's going on practically and how that influences sort of national decision makers. And hopefully that gives you a little bit of a snapshot of what we're planning to do. It's all very exciting, and it's good to know that there's some interest in your area as well. But I'm very happy to take some questions.
Thanks, Susie. Does anyone have any initial thoughts or questions at the minute? Yes. Oh, yes.
Sorry, I thought I'd start with a potentially stupid one, Susie. I'm not familiar with the outcome from the two sites. I've had some local discussions in the past. In my mind, this is very much from a talk and therapies or mental health perspective. This kind of lives in the same area as exercise on prescription, which I was first involved in about 24 years ago in some deprived areas of the west of Newcastle. Could you give me a sense of that interface with routine care and how you imagine it, whether it's going to be, if you like, from health to physical activity, or much more bi-directional around that?
Yeah, it's not a stupid question at all. It's a really good question. So the interventions that we've piloted so far have been a mixture, and again, this is based on what works for a service locally, a mixture of activity being delivered in service or encouraged in service, and then some of the interventions have been a referral out to a community sports organisation. They have not been exercise on a referral. I've tried as much as possible to have a needs-led conversation and work around actually how do you bring physical activity into your ordinary practice. How do you talk about it? How do you weave that into conversation? How do you keep it on the right path? What barriers come up, and what myths are associated with physical activity as well? That was a big one that came up in the pilots around people living with long-term health conditions, feeling that they can't do physical activity. It's not for them, scared of making their symptoms worse, for example. So some of them were a mixture of, and I'll give you a flavour for those that haven't. We did 10 weeks of physical activity in a step 3 CBT. So half an hour of the talking therapy and then 20 to 30 minutes of physical activity. Now that one was done online. So for those 20 to 30 minutes, people were encouraged to either go for a walk around their block and then log back in and talk about their experience. How did they feel before, during, and after? Some people stayed online and did a We're Undefeatable LTC workout that you can watch online. Others use things like Active 10 or Couch to 5K. So it was really facilitated around what works for you, rather than it's exercise on referral and it's in a gym and you're supported for X amount of weeks. And then, the conversation ends there. It's much more sort of holistic and needs-based conversation. The other interventions that we trialed were walk and talk therapy. So whereby, when appropriate, clinicians would go out with the service user and deliver the therapeutic intervention whilst walking. So that actually got staff out and about as well, which was a good one. And then we also did a long-term health conditions workshop, psychoeducational workshop, rooted around behaviour change principles, and lots of resources that are out there to help people move more. So this one didn't actually feature any movement within the workshop. It was all talking about why people aren't active, what the barriers that get in the way, what can help you. And there's a lot of peer-to-peer support with that. And that one ran every 4 weeks. And again, people pledged what they might do and how they felt doing that, and how they can weave it into their routine more readily and easily. So there's a big variety of the types of interventions. But I guess the main 2 points were they were either in service as part of the clinical sessions, and then others were actually a separate referral route out to the physical activity. Does that answer your question, Dale?
That's really helpful in terms of describing what's been trialed, if you like. I think if you spread the lens a bit wider than that in terms of what's being trialed, it's very difficult to match that to everybody using talk and therapy services. Whilst it may be generally helpful facilitation of self-management, if you like, people use our services because they've got a post-traumatic stress disorder, or obsessive compulsive disorder, or social anxiety disorder, or panic disorder, or a generalized anxiety disorder, or health anxiety, or etc., that is life limiting and disabling. And the session content, in terms of giving people the best possibility to resolve that problem, is pretty packed anyway, so it wouldn't be that you would be, for something like depression, or kind of outside of those range of problems, low self-esteem or comorbid physical health problems, you could see how weaving that in would be really creative, and happens with colleagues in pain centres or other places as well. But it's helpful to know what's been trialed. But I would just slightly advise, in terms of that interface specifically with talk and therapies, there been a broader look at that as well, in terms of the links in where appropriate, and who would be appropriate for.
The pilots worked with depression only, so that's one of the things to consider. The evidence base is probably most strong there, and more so moderate for anxiety, and you do then get I guess more of the specific activities where the interventions are stronger, for example yoga and Pilates, etc.
Oh, thanks, Susie. That makes a lot more sense now.
I've got hands in order. Here we go. Thomas, I think you're next.
Thanks, Susie. So I've got a question that's for you, and then I've got a question that's more directed towards colleagues at GM. So my question to you is, what are your expectations of a Trailblazer, and what support's provided? And to GM colleagues, how does this connect with existing interventions that we've done in this part of the system?
Yeah, good question. So the detail of that will be coming out in the guidance that we send out. So you'll be able to get much more detail on that.